Yes, we can start. Yeah.
Yes. Uh, so yes, today we are talking on a very important topic, that is prescription guidelines, which I think all of us, be it seniors or even juniors, we need to talk about this topic and get some guidance. I would now like to introduce the chairperson for this topic, Dr. Nilesh Shah sir. He has always been the grand teacher for all of us. He is the professor and HOD of Sion Hospital, and Sir has always been guiding all of us, and it is always a joy to listen to him because he always has something witty to say. So, sir, can you? I hand over to you. Can you start?
Thank you, Dr. Maithili. First of all, thanks for inviting me, and I'm very happy to be over here. I know Dr. Paraksha since last many years. We have worked together at IPS West Zone level in various meetings, conferences, and we have been co-examiners number of times. And we had very good interaction with each other. I know him as a very genuine person, very calm, composed all the time, very easily approachable. Students find him very good because he's always helping them. He never demeans or ridicule anyone or student. And I find him very sincere with his work. I know that he has been an inspector for many colleges where he goes and genuinely inspects each and everything. He also guides them how to get the recognition and also helps them. And whenever he finds some uh, big lacunas, he tells them very clearly that these are the lacuna and they should clear those lacuna. So I think if any of us require guidelines or guidance about how to prepare for the inspection, then he is the best person and he can tell us. So I think Manjali, next time when you keep a meeting and how to prepare for the inspection, he will be the best person to guide all of us. So that is about Dr. Paraksha. And the second, today's very important topic about prescriptions, how to write prescriptions and what are the guidelines and what are the practices. In our day-to-day clinical practice, we find lots of problem when we see a prescription from some other doctor. Now, I work at Sion Hospital and number of patients who come to Sion Hospital come from either some other hospital or they have met some other doctors in the past. So many times we see the prescription of the hospital, but who is the doctor we don't know. Some signature is there which we do not recognize and name of the doctor is not there, only name of the hospital is there on the prescription. And when we ask the patient who was the doctor, जैसे कोई डॉक्टर थे हम तो ये हॉस्पिटल में गए but we don't know who was the doctor, name of the doctor is not known. Second, the handwriting of the doctors. We are all famous for our handwriting, so handwritings are many times illegible and we don't know what medicine is written. Third thing is brand names. I think there are 625 different brand names for escitalopram alone. So if we usually write a brand name which is from some remote part of Maharashtra or UP, we have to find out what medicine is this and which medicine the patient is taking. And patient doesn't bring the medicine many times. So we Google it and sometimes we find it from Google, but many times that brand name we don't know and then we just keep on guessing that it must be escitalopram or aripiprazole or that kind of thing. So I think it is very important that we have a common guidelines, prescription guidelines, and we all practice that guidelines. And how exactly we should write the prescription, what all important precautions we should take, how should we practice. And I think Dr. Paraksha will kind of guide us on that. So, Dr. Paraksha.
Thank you so much, sir, for your kind introduction. And it's my pleasure to share today's session with both the chairpersons, Dr. Nilesh Shah sir and Dr. Maithili madam. It's my pleasure. I'm very excited for this session. And so I wish that throughout the session, any point of time, if you have any questions, please put it in the chat box so that we can make it more interactive. But I would request everyone to mute their mics during the session so that we can conduct smoothly. Let me share my screen. Yeah. Is my screen visible? Hello?
Yes, sir.
Yeah. Okay, fine. Yeah. So today's topic, prescription guidelines, laws, and practices, was conceptualized with an idea, as Sir rightly put forward, that something very basic for all the doctors and psychiatrists to learn in the medical schools, but still we see most of us, 95% of us, not doing it rightly. And today's session is just a revisit to our basics and primary lessons of our practices of writing a prescription. So, what I intend to share and my learning out of this exercise of this session is, I would like to share about what are the general basic principles as per the prescribed law and as per the expected norms of a standard prescription. What are the common mistakes? What are the details and solutions for that? I also would like to share something about the latest NMC guidelines about the prescriptions and the details that we all need to be aware about. I do not intend to share anything regarding the prescription practices with regards to the choice of molecules or the treatment guidelines for any particular disorders. I also do not wish to discuss anything with regards to the National Mental Health Care Program related directives. So the lesson is very clear and focused. There have been studies and research which very clearly have documented that the prescription errors account for almost 70% of the medication errors. And we all know how it affects the well being and the treatment of our patients. As per the Right to Information Act, it is the inherent right of every patient to have a correct and clear prescription from us. There are studies which have proven that the legibility of doctors' writings were assessed, and it was found that the doctors' handwritings were compared to other healthcare professionals and administrators, and were found to be worst out of all practicing in a hospital. There have already also been studies in India which have tried to find out the kind of prescription practices and how much out of the way they can be. They have found that out of 1,000 prescriptions, almost 514 had lapses, and almost 82% of the patients or the charts in the indoor case records were having problems with regards to the prescriptions and the details regarding it. So it's something which is very, very common. Now we know, we have identified, there are regulations, laws, and it's important for us to keep ourselves abreast with regards to what we are supposed to follow. It is our responsibility as a prescriber that what we write on that piece of paper is a formal, official written order. We are bound to follow all the regulations with regards to the safe prescribing norms, which are very well laid down. We need to continue to monitor the standards of this documented proof of whatever treatment or care we have offered to our clients. And it has a lot of legal implications. And so it becomes more imperative for us to understand the nitty gritties of writing a prescription. So there are so many guidelines, government and national, international, which have thrown light and guided all the registered medical practitioners to understand that how it has to be done. One of the very good one which I found was as suggested by Government of India's guidelines for prescription audit. What it states is that each and every prescription should have this following things. One, it should have a date, a time, and a place where it is written. The date can or shall also be mentioning about the validity of the prescription, up to what date the patient can use it to get the medicines being dispensed from pharmacy. There should be patient information, which includes complete name, not just name, complete name, the age, the gender, the address of the patient, identification number or the hospital case number, the phone number of the patient, which is very vital for the hospital and doctor's records, and the weight of the patient. Also, there should be a kind of an allergy tick mark or a box on every prescription, which should be mandatorily be filled up if at all it is relevant. The prescriber's information, doctor's information on every prescription should include that it has been written only by a registered medical practitioner, a qualified degree and a registration holder. Nobody else is allowed to write a medical prescription. It is mandatory that those who prescribe, they have their full name written. They should have signed in real with a blue ink and a date against their name. Even if it is a printed prescription, the signature has to be original and signed. There has to be a registration, medical council registration number mandatorily mentioned, the address of the hospital or the doctor, and the contact details. Preferably, most of this should be part of the stamp below the signature. There should be details about the follow-up visit advised to the patient, as well as the emergency contact numbers in case of requirement during off hours or in between visits. A lot of guidelines have clearly stated that it is advisable to write a very short history, if not history, at least a provisional diagnosis and important findings and vitals and general examination over the prescription, maybe in a very concise and short manner on one side or on the back of it. It serves multiple purposes. Nevertheless, as every one of us know, legibility is the burning issue, the major issue, and the biggest problem creator for all the prescribers. So as legible as possible is the bottom line. Never forget to put a slash mark in between your last prescribed medicine and your signature. Something what you do in a bank check when you issue a check. You see to it that don't leave any blank places. Similarly, it is important while writing a prescription. Everything written on a prescription is as important as writing a check, and everything can help you or harm you, provided if you have not taken due care. Something related to the drug information. What we should be writing. We should always be writing the drugs in capital letters and generics only, as per the existing guidelines. Frequency of the drug to be taken, the dosage form, the route to be administered, the strength, the time of the day when to be taken, with without food, total duration of the course of the treatment of that medication, and the total quantity to be dispensed by the pharmacist. Each and every parameter is important and particularly to be mentioned. It is also important to write all the drugs in a chronological fashion, starting from co-medicine to supplementary medicine and symptomatic medicine. Also, writing the injectables first, followed by the oral medications, and then at the last, the topical medications. There should be no overwriting. And in case, if you have to, don't forget to put a counter sign against it. Your prescription is a very important official legal document. Any tampering, any change by you or by others has to be answerable. So don't forget to verify the authenticity and completeness, and countersign any changes made by you. There are certain drug related information that all of us need to understand. You should always use letters along with numbers if you think that there is a doubt of fabrication being happening later on after you hand over the prescription. Many a times in psychiatry, we write clonazepam 10 tablets, but then somebody between the hospital and the pharmacy make it 40 out of 10 and get 40 from the medical store. So whenever you feel that you are seeing a client or there is a possibility of manipulation or any fabrication into what you have been given, you can always write things in words along with numbers as you do in a bank check. You should always remember that you should write a kind of a leading zero. That means zero before the decimal point should always be written when you write the strength of the medication, but avoid writing zeros after the decimal as far as possible. This helps in preventing the errors in dispensing. When medication is needed to be discontinued, the word discontinue should be clearly mentioned. If in case you are using the same prescription or altering it while prescribing. You can keep a note to the pharmacist, maybe at the bottom of the prescription, with clear instructions and advisory that needs to be followed by the pharmacist. For example, prescription not to be refilled again or substituted with another medicine. Also, don't forget to keep your contact details clearly eligible, read by the pharmacist. Specific advice for the patients if in case something like over and above the basic drug related details of consumption, you can also mention something like how in general the drug is expected to test or cause some minor side effects, kind of a communication formally for the patient to remember after they go back home. There are a lot of guidelines and criteria to be kept in mind while using symbols and abbreviations in a prescription. Abbreviations of medicine name, such as QID or OD, should be avoided in a prescription. If you want to convey the same to the patient to make them understand how it has to be taken, please use local vernacular language and in a way the patient can read and understand. Do not use symbols like greater than or less than. Do not use abbreviations for microgram and nanogram. mg, ng, or micro g kind of symbols can create a lot of confusions because a single difference in interpretation can make changes of 1,000-folds dosages, something like thyroxine. The strength of the medicine should be stated in standard units using abbreviations that are consistent with general international systems. Like micrograms and nanograms should not be abbreviated. Again, do not abbreviate units as U, since handwritten abbreviation in the form of an alphabet U can be easily misread as O or 4 when you don't write very clearly and legibly. Don't use abbreviations such as D or C for discontinue, ECA for to come again, or CST for continue same treatment or similar kind of short forms. Errors due to mix-up between numbers and alphabets like I and 1, O and 0, Z and 2 should always be taken into consideration. Abbreviations or acronyms for medicines name should not be used. Example, PCM for paracetamol, CPM for chlorpheniramine. We all very well know that sometimes we do use this, especially within the internal communication among doctors or hospital, but especially when you are expecting a patient or a pharmacist to read this, dispense based on this, and consume the medicine based on this, do not leave any trace for doubt. This is how an ideal prescription looks like. We can see that there is a logo, name of the hospital, clinic, address, phone number, patient's name completely written, the ID number, age, gender, address. There should also be the weight, phone number, diagnostic details. On the left-hand side column, the clinical details have been mentioned. On the right-hand side, the generic name of the drugs in capitals, dosages, method of being taken in Hindi, a lot of things, specific instructions to be given about the kind of things to be avoided or taken in Hindi language, the signature, the registration number of the doctor should have been there, a stamp should have been there, a full name type written should have been there. So I think this prescription is still not complete. Coming to the MCI Code of Medical Ethics, what is a prescribed law for us to issue a prescription? The original document of 2002 mentions that according to the regulation, a doctor's prescription should also make clear that if he or she has himself or herself dispensed any medicine to the patient. It's not just, so I'm going to highlight certain things over and above what we have already shared. It's not just the prescription that matters. It's certain other details which also is important. Something like, have you yourself given or dispensed the medicines along with the prescriptions being given to the patient? Please mention there. Regulation for 1.4.1 requires that every prescription should carry the registration number of the prescribing doctor. The pharmacist should check every prescription he comes across while dispensing medicine and can refuse in case of there is no registration number. It prohibits dispensing of secret remedial agents by doctors whose composition they do not know. This regulation also considers the manufacture, promotion, or the use as unethical. All the drugs prescribed by a physician are carrying a proprietary formula and a clear name. Both should be there. It states that a registered medical practitioner should not issue certificates of efficiency in modern medicine to any unqualified or non-medical person, but he or she can issue such certificate to dispensers after proper training, which means that if I am having my clinic, I want to dispense medicines from my clinic, I do it from my chamber, from my table, and if I seek help from a person to do so, that person cannot be a non-medical person or unqualified person. They should be somewhere having a medical background for eligible to dispense medicine along with me. It states that as far as possible, drugs should be prescribed with generic drugs names. Now it is mandatory. Every doctor should make sure that there is a rational prescription and use of drugs. There's a lot of emphasis on rational prescription. There's lots of literature, discussions, training programs on what to consider a rational prescription for every condition in every specialty. Efforts shall be made to computerize medical records for quick retrieval as far as possible. These are the guidelines from the National Medical Commission. It also states that use generic name drugs should be used rationally and prescribed legibly and in capital letters. Especially for this clause 1.5, there is also a punishment which includes certain disciplinary actions if your prescription is found not to be following this. These were the guidelines by the NMC to begin with, existing since years. And then in August 23, we had certain amendments and changes to it. This is what NMC has recently prescribed as an ideal prescription format. This includes almost everything that we have already discussed. As you can see, the details. This is the mandatory guideline to be followed. So if your prescription is not having even this much of details out of everything advisable, it is not a valid prescription as per NMC. Now, coming back to the generic medicines and prescription guidelines issued with the similar regulation in August 23, it states that there are different nomenclatures and NMC has tried to define each nomenclature. It states that generic name would mean non-proprietary or approved name of a drug, as also known as generic name of the drug. the pharmacological name. Non-proprietary name is the name accepted by a competent scientific body or a regulatory authority. Something like paracetamol. Generic drug or medicine is defined as a drug product that is comparable to the brand or reference listed product in dosage form, strength, route of administration, quality, and performance characteristic, and intended use. There is one more term now into use, which is called as branded generic drug. A branded generic drug is one which has come off patent and is manufactured by drug companies and sold under different companies' brand names. These drugs may be less costly than the branded patented version, but costlier than the bulk manufacturer's generic version of the drug, that is typical proprietary name drug. There is less regulatory control over the prices of this branded generic drug. What is the guidance to the doctors now? It is you should prescribe drugs with generic, that means non-proprietary or pharmacological names only. So what they want to state is that not a branded generic, not a patented branded, but a non-proprietary pharmacological name. In case of drugs with a narrow therapeutic index, something like anti-epileptics, biosimilars, and similar other exceptional cases, this practice can be relaxed. So you can continue to prescribe the same trade name if you wish. You should prescribe drugs rationally and optimally. Both over prescribing and under prescribing are to be avoided, keeping in mind possible interactions. Fixed dose combinations are to be used judiciously. You can use it as less as possible. Only approved and rational fixed dose combinations are to be prescribed. You should encourage the use of generic drugs by all. Avoid prescribing branded generic drug. Now, this is the clause being introduced in this regulation recently, which rules out the possibility of prescribing a branded generic. Encourage patients to purchase drugs from Jan Aushadhi Kendra and generic pharmacy outlets. Educate everybody and try to promote the generic drug usages. The written prescription should be legible and preferably in full capitals to avoid misinterpretation. It should be typed and printed as far as possible. There is a concept now that NMC and Government India is advocating, and that is prescribed rational and prescribed generic. Both these are now the focus. There are also been provisions of a suspension as per the penalty from the NMC for violating the norms. Coming now to the telepsychiatry guidelines, because when we are practicing telepsychiatry, the prescription practices can change and differ, and there can be some different guidelines for us to follow. There are certain concepts like the prescription in telepsychiatry consultation is solely at the professional discretion of the doctor, which means that you can have an appointment, you can have a consultation, you can maybe have detailed history examination, maybe diagnosis. But if you feel like that you are not confident to give a prescription, especially in the first consultation, you may not. Same professional accountability as of in-person consultations holds true even in telepsychiatry consultation, especially with writing a prescription and the legal aspects related to it. So we should try to comply with all the guidelines that otherwise we do in a routine practice. Only when you are satisfied that you have enough and adequate relevant information about patient's medical condition, you're sure and confident about the diagnosis and the line of management, then you should issue a prescription. You should prescribe drugs without following due, if you do it without following due process of arriving at an appropriate diagnosis, it may amount to professional misconduct, which means that you should not issue a prescription online based on some symptomatic relief or a vague, rough idea about patient's problems. If you are giving a prescription online, you should be clearly, confidently knowing about the complete picture clinically for the patient. Issuing these prescriptions online, you can take care that you also have a clear photograph or a scanned digital copy of what you are giving it to the patient. Keep a copy with you. You can give it via email or via any other messaging platform. Patients who do not have a smartphone, by using an online web application, you can share the prescription. They can access through the mobile browser. Patients coming from remote villages, simple mobile phone can also utilize this facility and avail the telepsychiatry consultation and e-prescriptions from you, as simple as through an SMS from you. You need not give or even keep a printed copy of the same. You can have a digital copy of the record with you. This prescription, which is issued digitally, is valid up to 2 weeks from the date of issue, or when dispensed by the pharmacist, whichever is earlier. E-prescriptions can also be directly sent to the pharmacy sometimes if you are working in that kind of platform. In that case, do not forget to take the consent from the patient for which pharmacy they want to buy the medicine from and what is convenient to them. Do not decide or choose the pharmacy shop on behalf of the patient. Let the patient do that or get his or her consent. The NMC guidelines for telepsychiatry prescriptions and prescription guidelines states certain criteria for use and prescription of medication. So they have classified the group of medications into 3 groups, O, A, and B. O is something very general. Most of us can prescribe it. The group A medicines, the list of medicines you can only prescribe, especially in the first consultation. Also in the follow-up consultation, only with a video consultation done, not in any other method. And the B category of drugs, you can prescribe during the follow-up consultations if you have continued your follow-up consultation in any method of telepsychiatry mode. There are certain prohibited drugs which have never to be prescribed online or digitally or e-prescription wise, and they should not be prescribed. Let us see what are this group of medications. So O would be something like drugs that are safe to be prescribed through any mode of teleconsultation that are used for common conditions, something like over the counter, can also be received without a prescription, something like antacids, antihistaminics, antipyretics, etc. Group A, which mandates that we should have a video consultation, and also for the first consultation, this can be used only with a video consultation, means these are the drugs that you can prescribe, something like antifungal agents, antibiotics, something like drugs for asthma, diabetes, hypertension, tuberculosis, all those conditions or medications which have some regulation, some scope for misuse, overuse, resistance, complications, and side effects being possible. So close monitoring and very sure of its judicious use has to be ensured by video consultation. Whereas the group B would include all the drugs which are add-on drugs which can be used over and above the over-the-counter drugs for managing the existing conditions, something like drugs which are used as an add-on to an antihypertensive which is already been going on for better control. This can be done without a video consultation, especially in follow-up visits with routine telepsychiatry or teleconsultation methods. Especially for psychotropic and narcotic drugs, there are clear guidelines. And the NMC guideline for telepsychiatry in general prohibits the prescription of most of the drugs, except clobazam, clonazepam, and phenobarbital, as per these regulations. This is an ideal prescription of what is expected out of a digital or an e-prescription issued by a doctor to a patient through online platform. More or less, more or less, it's almost similar what NMC has prescribed for offline consultation. Now, coming to something else, let me share that what are the rules regulations. I tried to search about my patient going to other countries with my prescription. What are the norms? So there are norms pertaining to carrying medicines along with you with prescriptions differing from country to country. Some of them I would like to highlight here. Suppose if your patient is going to Australia, what does the rules say? He cannot bring medicines to Australia for anyone else than himself or an immediate family member traveling along with the patient or the family. The medicines cannot be used for sale or supply to another person after going there. It has to be retained in its original packaging and with all dispensing labels, with a very clearly identifiable names, tags, and everything. There has to be a prescription given by you, which has all the details as discussed before, to be carried with the prescription, and preferably a letter from a doctor clearly stating and request to the Immigration or Customs Department to permit the patient to carry along with them this much medicine with this much quantity as advised by you for this condition for this much tenure. A person should not be, mostly would not be allowed to carry medicine beyond a 3 months supply. They can use this for their personal medical condition only. And they should carry back all those medicines which are left while they go back. Somebody going to stay for more than 3 months, there are rules and regulations in place and how they can import or request a courier or a parcel from a family back in India to be received in Australia to continue the same medicine beyond 3 months. It's a different issue that I, being in India, cannot consult or prescribe my patient being in Australia as per telepsychiatry rules. But in case if the patient has a valid prescription from somebody from India and they want to use it and the medicines needs to be supplied to him or her after 3 months, there is a mechanism to be used by that person and continue the same medicines there. Similarly are the guidelines if you're traveling to UK, the same almost similar kind of thing. So person is allowed up to 3 months of supply. Beyond that, you can request the customs department to import or invite a parcel of medicines to further continue your medicine till your intended stay in that country. There are clear guidelines they have stated as to what, how you have to do. Similarly, a lot of our patients going to Dubai or Middle East. Similarly, they have their guidelines, which again states that you can carry certain medicines almost up to 3 months, but then there are certain restrictions, something like these are the kind of clear directives that UA gives. This is the list of medicines which they say that you can carry along with you for 3 months with a medical prescription, valid prescription carried along with you, which includes the benzodiazepines, the Z group of drugs, pregabalin, trihexyphenidyl, buprenorphine, methadone, dextropropoxifen, ketamine, midazolam, methylphenidate. All those which falls into the warranted categories, prohibited categories. But if you have a legitimate medical condition, a medical prescription and a paper to support, you can still carry for 3 months. But there's a strict no, even if you have a prescription to carry any kind of synthetic cannabinoids, tetrahydrocannabinol, or any kind of psilocybin or its other congeners. Coming to India, if my patient or some other patient is entering into India, I think the laws for them to carry medicines while entering India also states almost similar things. So if your patient is an NRI patient or they are already on treatment overseas and they are coming to India to see you and they ask you how, what we should carry and what is permissible in India, these are some of the rules. They should carry quantities of drugs for personal use only, provided that it is being clearly declared as their personal property as a part of their luggage. to the customs authorities. The quantity of any single drug that they are coming with in India should not exceed 100 average dosages, which is almost 3 months, provided that the licensing authority may, in some cases, allow larger quantities. The Indian authority, on an application made, is satisfied that the drug is used for a personal purpose only. And there is a licensing authority which is covered by a prescription from a registered medical practitioner that they have consulted for. Something to focus on: prescription pads. Things very simple, but commonly missed. You should always keep your prescription pads in safe custody, even more important in psychiatry. Your plain printed prescription pad can be misused by anybody out of your knowledge if you keep it in your consulting room open enough when you are not present to be misused. And it can only be proved that you have not issued this prescription later on when the legal issues are complex enough. So this is something like a blank checkbook. You would never keep it open. Keep it in safe custody. Don't use another doctor's prescription pad. Avoid using pad bearing 2 or more doctors' names. You can very well understand things are very clear, very precise, and directive. Avoid using pads with a mark of available XYZ, medicine XYZ store, etc., or any kind of advertisements or any other information, somebody who has supplied free prescription pads or anything like that. Always avoid these things. At the end, I think the gist is that a lot of things can be done right and errors can be avoided in prescription if we try to practice more of digital, printed, and computerized prescriptions. We need to set the format once and then follow it almost for every time so as to avoid remembering all the details in every patient. In USA, since 2003, almost every prescription being issued is a computerized printed prescription. Maybe sooner or later we can adopt that policy as much as possible. Otherwise, be more particular, be more legible, and a bit more meticulous and systematic in creating and issuing the legal and official document that is the face of us and the face of what we did with our patients. Thank you. Sir, we can't hear you.
Thank you,
Yeah.
Dr. Paraksha. That was a wonderful, very, very informative presentation. And I'm sure we are going to have number of questions. And I have a few questions myself. Sometimes what happens that these guidelines are prepared by the people who have not been writing the prescriptions. Now, say for example, I have lots of concern about writing the diagnosis of the patient on prescription, which is mandatory. Now, see, patient doesn't want to reveal his diagnosis to anyone. Then why it should be written on the prescription? And it's a question of his confidentiality, whether he has hypertension, whether he has diabetes, or whether he has depression or schizophrenia. Why the diagnosis should be mentioned on the prescription, which anybody can read. Like he gives a prescription to a medical store person, there are 3 people who are going to use his prescription. One, somebody will take, somebody will give it to another person, third person will take out the medicine, another person will pack the medicines. So that is one very thing that why diagnosis should be mentioned. Second,
Can I answer one by one?
Yeah.
Yes, sir. Sir, I think there are multiple obligatory duties that we have to handle at the same time. I definitely agree with you that the confidentiality holds more importance than duty to write the diagnosis on the prescription. The very purpose of writing the diagnosis, as explained by the rules, is that it helps even the pharmacists to know in case if there is any confusion with the medicine, its dosages or some handwritings. In order to avoid any dispensing errors, it is expected that the pharmacist can also use his own intellect to understand that what disorder it is being used for. This is a very gross idea. Again, a prescription written by you can be seen by me in a follow-up patient. Somebody consulting you before and now me. When I go through the prescriptions, I have to rely on the possible diagnosis only based on my presumption of for what purpose this medicine may have been prescribed by you. So sometimes in a lot of clinical practice, although there are rules laid down to issue medical records to the patients, a copy of it for their reference, which can include all the clinical details. But if not, and only the prescription is the paper being exchanged with the patient, short history or diagnosis can also help the future doctors being consulted. But I do agree, if I was in your case and I have to weigh both the things, I would weigh the confidentiality of the patient much more. Maybe I can ask for a consent of the patient that, do you mind if I write that on your prescription? Uh, Whether your family can read it or the pharmacist can read it or anybody would be able to know what you have, the patient can decide the final say.
And many times we don't know the diagnosis. It's a symptomatic treatment. So second question is encourage the patient to buy the medicines from Jan Arogya Kendra. It's like saying that encourage the patient to take treatment from municipal corporation or government hospital and don't send him to private. So all the family physicians should send the patients to. Now, this is absolutely no in our kind of country where everybody should flourish. So why NMC should insist that it should be only from Jan? Because see, they have given license to the private medical stores also.
Yes, sir.
So
Yes, sir.
that is a breach of contract, and then you are so we are kind of favoring Jan Arogya Kendra against the other medical stores.
Yes, sir. So there are a lot of contradictions. There is a lot of gray, debatable, controversial areas related to this. I understand absolutely, and as a clinician, and when we think about the best interest of our patients, and when we feel ourselves responsible and accountable for what we are offering and doing with our patients, and in the best interest of the patients primarily, I do understand and agree with your viewpoint. This presentation and this point was just to sensitize all of us that what are the rules as of now as prescribed by the regulatory authorities. I do not mean that they are the best options. Yes, sir.
Yeah. Similarly, generic name. Now, suppose it's a it's a multivitamin which has 7 components, or a liver medicine where there are 7 or 8 things. I have to prescribe by a brand name. There is no other alternative. I cannot write folic acid 1 milligram, maybe another thiamine so many milligrams, pyridoxine so many milligrams. So I think there are lots of difficulties. We have to mention the time of the at what time that thing was prescribed. Okay. So I think they have made it more and more difficult, and so that less and less people will follow the guidelines. I don't think if you actually go and check, not even 1% of the prescription would have uh, uh, fulfilled all the guidelines. But anyway, I think it was an excellent presentation and lots of thing which we did not know that these are the guidelines. And there are lots of questions. So we'll start with our Dr. Bhavesh Lakdawala. Sir.
Yes, sir. Parag,
Yes,
Parag, I
yes, please.
want to ask that, like we are working in a municipal corporation hospital, and you said that all the details should be mentioned in a prescription, like full name, age, but the prescription pad is so small, we cannot uh, enter all the details of the patient. We can only write the generic name or the brand name of the drug. Ideally, a generic name we are using. So, what is your view about this?
So can I ask you why the pad is so small, and How come the pad is so small?
Yeah, that cannot be the excuse.
Mm.
It
Yeah,
means that it has been provided to you by
yeah,
somebody
yeah.
without a thought. It is your responsibility to decide what should be the size of your prescription, not somebody else.
But whole hospital is using the same type of the prescription.
I
That
understand,
cannot be
sir.
excuse. That cannot be the
Yes, sir.
excuse.
So we cannot use any pharmacy or medical store provided pads, chit pads, or even pharmaceutical company provided any kind of pads with
No, no.
anything printed.
Yes.
Yeah. So basically, it is our responsibility. As I said, if you are writing on it, that piece of paper is 100% your responsibility. You have to see to it that you are doing the right thing. And if you are not doing it, you will be responsible for what you are doing. So you can think about solutions if you, whatever you, something like as simple as, if I can give you an advice, uh, you have blank papers available in your hospital for writing letters. You can use those things. Use a big size paper and write all the details. If time permits, and if you think that you can mention all these details in every prescription and you are like ready to do it, because it's exhaustive. I do understand that it's very convenient to scribble 2 3 words or just the name and signature and let the patient go. But that's what this session is about, that we should know what is mandatorily expected out of us and what we are doing, and the difference, the gap between it. How much you can breach this gap is up to you, but we should be aware what we are doing and what is expected. So that is the bottom line. Whatever all the things which I said are almost all required, and more than one regulatory agencies or guidelines have clearly stated that. It's a different story that 99% may not be doing it, or nobody in my hospital is doing it, but I should know what I'm doing at least. As much as I can follow, it's good. And it's not just following the law, it's also good for my patients. See, if I write in a Hindi or Gujarati about the way the patient has to take the medicines, it's going to help my patients. If I'm going to write clearly in capital handwritings the name of the drugs, my patients would be receiving the right drug from the pharmacy. So there's a lot of patient care involved into prescription writing also.
Yes. So thank you.
Thank you.
Dr. Maithili, there are quite a few questions. Can we go on, or do we want to stop at 9 o'clock?
So we'll take just a couple of some questions.
Okay, 2 more questions.
I'll
Okay,
read
there
out.
is a, yeah, okay, you can read out. Yeah, by Dr.
Was the
Anup and
rationale
Dr. Rohit.
not-
Yeah.
Yes, sir. Was the rationale behind not prescribing branded generics? As there's a specific note about it.
Yeah, so whatever has been mentioned in the documents, it's something like everything revolves around cost. The major focus, and probably the only focus, is cost. So what they have considered is that branded generics may not be as costly as patented brands, but they are quite costly than the proprietary generic drugs. So that's the reason being given.
And what is the maximum duration for which we can prescribe drugs? Sometimes to go to little and ask.
Yeah, I could not find a very clear answer to it. Maybe Nilesh sir can help us to understand. My understanding is that it can vary from the first and the follow-up consultation, but I think it should be around 3 months. Sir, do you have any idea?
Yeah, I was also under impression it can be around 3 months, but we have number of patients going abroad and number of patients coming from distant part of India. So we prescribe for 6 months, 1 year. So far, nothing has happened, touch wood, but sometimes we can be in difficult situation if somebody would question that why did you prescribe for 4 months or 6 months. But yes,
So,
guidelines probably for 3 months.
so in that case, can we give a post-dated prescription?
Very difficult because that I would never do.
Yes, yes.
Because that is a very difficult. I usually make a mention that as a special case, this patient was going abroad or patient is coming from far distance. Therefore, the prescription is given for 6 months. I try to justify, write a note
Yes,
Probably
yes.
that would save me, justify my going against the rule.
Yeah, sir, I agree. A lot of things which we may be deviating from the norms, and if we think that we want to be more defensive or clear about it, either we can use the justification of clearly documenting the reason that in the best medical care and interest of the patient we are doing this, or we can use the reason of patient's consent, like the patient has volunteered or requested for the same, and so we are doing it kind of. Yeah.
Yeah, but that may not be valid. See, patient might say for 6 months or 10 months or 1 year. We have to do whatever we think is the right. And if you feel that yes, the patient needs for 6 months, otherwise he will relapse. Like in many patients with schizophrenia, he has to continue for very long time. So in that case, I think our justification would be more valid than because the patient wanted for 6 months, I gave it for 6 months.
Sir, what I generally do, if the patient requires treatment in OD dose, I write in BD dose. So the patient gets double the dose. So this can be a practical solution.
Can I say something?
Can we have the
Yes.
questions complete
Yes.
first?
Yes,
Yes.
yes.
Yes,
There
I
is
think, Dr. Balchandra, I understand our empathy for our patients, but
Mhm.
this would be a very risky thing. Although for the welfare of the patient, you should not be officially writing a prescription which you do not intend your patient to follow. And like verbally, you explain them that take it OD, I'm writing BD. Do
Mhm.
not do that. Do not do that. Do not do that.
Mhm.
Maybe other ways or other ways out can help, but see, written things can speak forever, and you can never ever deny what you have written. It means for all purpose you are prescribing and advising to be taken BD.
Mhm.
Yeah. Yes.
one more question. When patients report poor result with a generic brand and seek a specific brand, should we mention so on the future prescriptions?
Yes, I think the premise of writing a generic drug is for the patient welfare, for the cost effective purpose for the patient's pockets. And if the request very specifically is coming from the patient side, I think you should document, and then you can use that for justifying the prescription. I think that's fine.
And there is one more question from the audience. They have asked that we write only if that is okay.
I didn't got you.
So there are the next question is a set of two questions. Is sometimes mentioned this is not for medical legal purpose. And secondly, that sometimes we write only the word CT all.
Both are not acceptable. Every prescription is a medical legal document. Even if you refuse to accept or write, it is not. Uh, See, it is up to the court to decide the weightage of that evidence in a legal scenario. Most of the courts would consider it as a valid medical official document because that's the primary and the only documentation of the treatment patient has received, basis on the basis of which the case or other things are going on. City hall, no way, no way. Even in indoor cases, even in indoor case histories and sheets, uh, or follow up patients in outpatient consultations, avoid writing city hall. The rules says clear no.
Uh, Thank you. So if I may ask one more question, are there any rules for prescription when patient is absent? That is often on CT all we see relatives coming for medicines. The patient is working.
Yeah, so they say that the most ideal situation would be you should not give a prescription without the physical patient presence of the patient. But conventionally, a lot of guidelines they have mentioned that the first consultation has to be in person always, where you have been sure about your diagnosis, clinical impressions, all examinations being done, and patient is being clearly examined and treated primarily. Uh, Follow-up consultations can be sometimes without the physical presence of the patients, but you can write that on a piece of like the case paper clearly that this is what like prescribed without the physical presence of the patient. You can do it maybe once, twice, or within 3, 4, 5, 6 months, once or twice, but you should be then expecting the patient to see you at least once in 6 months. So that's how some of the guidelines have tried to help the patients or the families. Nilesh sir, would you like to add?
Shah sir. Sir, please you, Shah sir.
His screen is freeze.
Yes. Okay. Till then, I think we can go ahead or
Parag bhai,
yes.
do you follow what you have mentioned in your presentation? How much you are able to follow?
More than 50%?
More
Not
than
all.
50%. Okay.
So we have already have, even in a government setup, we have already have prescribed prescription pads.
Mhm.
So we have a lot of things in place that we have to fill up, and we don't forget while issuing prescriptions to each patients. So yes, not 100%, but yet.
Okay, sir, then one more question let me answer. Are there any guidelines for prescribing non-specialty molecules that is not related to us? This could be two types, one related to other specialty and one which could be simpler molecules like paracetamol, cough syrup, which even a MBBS can prescribe.
So one thing is very clear, nothing outside allopathy is allowed. So I cannot prescribe Leo 52. Okay. But within allopathy, I have all the rights to prescribe within my specialty, and outside my specialty, as a registered medical practitioner, I can prescribe for general conditions, common medical conditions. I can prescribe that things.
Yes. Any other questions from the audience? We are waiting for Shah.
Sir is back.
That yes.
Hello.
Yeah, I'm back.
Sir, there
Yeah.
was a
Yeah.
there was a question for you that is it okay to issue a prescription to a family member in physical absence of the patient?
We do prescribe to the patients because many of our patients are not able to come to the hospital. And if the patient is not there, we make a mention that family so and so family member had come. He has reported so and so, and on the basis of that, we have given the prescription. So at least at Sion Hospital, we give the prescription even if the family members are not there.
So there is one more question that if we are prescribing medicine, say for a month, it has been asked that do we write till exact date that it is valid to, or we can just say valid for 1 month?
Usually we
So-
write for 1 month. Sorry.
Yes, sir, please. Yeah. So they say that there can be two ways of writing. Either you write it, suppose if it is 1 BD, you write it one tablet in the morning, one in the evening for 30 days. And the pharmacist would calculate 60 tablets. Or you straight away write down that pharmacist to be dispensed 60 tablets for this, and then write down instructions for patient how it has to be taken, once in morning, once in evening, kind of, which also means for 1 month.
Yes, sir. So there is one more question. For how long can we give norphin naloxone tablet to patient?
I guess this question pertains to the prescription, more than prescription, the treatment guidelines. Is it so? Because it would vary from the clinical scenario and the kind of treatment being going on in that kind. So nothing to do with the prescription guidelines. I think As far as those drugs which are not controlled drugs like buprenorphine, the remaining all psychotropic medications have the similar regulation as we have already discussed, to be followed. Like you can give it for a couple of months. All those prescription guidelines have to be followed. It is almost similar for all other psychiatric medications, including benzodiazepines and others.
Parag bhai,
Yes, sir.
can I add about buprenorphine?
Yes.
Yes. In the ATF center, which is running in the India and Gujarat, it is says that buprenorphine should be given daily to the patients, initially for 3-4 days. And after that, you can give for at least 5 days or 7 days, depends upon that patient coming regularly in follow-up. And it's totally depend upon patient to patient. We never give beyond 7 days. That is very clear from our side. Preferably to dispense daily for initial 3-4 days. This we are following. Thank
If
you.
I can add to this, we are also running ATF. In that, in the training, it was mentioned that for the at least 3 months, patient has to come regularly for the buprenorphine. And after that, if you found that the patient is very regular, sincere, then you can give the buprenorphine naloxone combination at home. But that also should not be very long duration, like initially for the 3 days, then 7 days. As you feel that patient will follow your advice, and you feel that patient is really sincere. But for the first 3 months, buprenorphine should be given daily. Patient has to come daily.
Yeah. So I think apart from the clinical scenario and individual need-based dosage schedule or directly observed treatments, or how much do you clinically judge the risk of abuse, you can have a very individual plan for each patient. But maybe the question something like, if somebody is stable already and you have no doubts about misuse or abuse, even though that's a possibility always, considering the best case scenario, how long or the longest would you prescribe? I think that was the question. Any idea?
Buprenorphine, I would never give beyond 10 days.
Yeah, it is. It
Okay.
should not be given more than 10 to 15 days.
But then he will go back to brown sugar or whatever he's taking.
Yeah, but guidelines do
But
not
sir,
permit.
No, see, the whole purpose is marred, no? See, somebody wants to leave brown sugar. You are giving buprenorphine. You say, I will give you only 1 day medicine. Next day again he has to come here. Now in Bombay city, the center is at KEM hospital and patient staying at say Vasai or Virar. Now he has to travel for 2 hours to come to center. He gets 1 tablet or 1 day tablet, 2 or 3 tablets. Again he goes back. Again next day he has to come. You are deterring him from taking treatment.
Yes, you are.
So at least if you give for 7 days, and then what about his work? You don't want him to work in the regular day. Only come for 2 hours, take 2 medicines, go home, and don't work at all. You want him to work. And see, if he has to abuse, he can abuse buprenorphine also, and he can abuse brown sugar also. So if you feel that you want to give him for at least 7 days, no, and then you give it for 15 days so that he can continue. Your hospitals are closed on Sundays. He is working from
yes,
Monday to Saturday.
sir, problem with the buprenorphine is that most of these patients who are opioids or crude opium or artificial opium or synthetic opioids, they are living in the groups and they also take the substance in the groups also. So what they do, they share with each other. That he taken the tablets, आदि उसको दे दिया, and they also sell the tablets sometimes. We have observed this. So
So even
I
if you
don't
give
know,
for
but
1 day, he will go and sell it. No, 1 day also he
yeah,
can sell it. Every
I
day
do
he'll
agree,
come, he
sir.
will take the medicine and he will sell it.
But at least 7 to 10 days is a ideal time, I think so. And that keeps us. I observe that genuine patients who really need the treatment, they definitely come within 7 or 10 days. Even for substance, they have to go daily, sir. This is also in keep in mind. To procure opium, heroines, anything, they have to go daily and bring that substance.
See, that's why I had gone to one of these hospitals where they have this de-addiction center of excellence where patients are registered and given this buprenorphine and other tablets. Number of patients registered in last 10 years are 70.
Mm.
So I said 70 patients and the budget is some 70 lakhs.
Mm.
And I said, how many brown sugar addicts are there in the city of Bombay or opioid? And you are giving this medicine to 70 people. How cost benefit it is.
Yeah, I agree.
So I think that if he is going to fool you, he is going to cheat you, he can cheat every day. No? If he is staying nearby, he will come, take the medicine and give it to someone else.
Generally,
And
sir,
he
one
may
or
not be
two
taking
follow-up.
brown sugar. He may not be taking brown sugar. He will come and say, I am taking brown sugar.
Yeah. So generally, 2 or 3 follow-up, we came to know that this is genuine patient or something is messy is going on. So it depends upon.
I think
you are saying
Western
very
standards
practical
when we follow the Western standards without kind of realizing the ground realities, we have to face this.
It's, I think our national center is also doing that.
Yeah.
Shall we close down?
Yeah, there are a number of
uh,
questions,
if-
but I think
we are falling short of time. Sir, if you would want to add anything, your input.
Nilesh, sir?
are you asking
Shah,
me?
sir.
Yeah,
Yes, sir. Shah, sir.
I think the guidelines are to be taken as guidelines and they should not be kind of mandatory or law. You can prescribe good guidelines. You can say these are the advantages of following guidelines. Simple thing like you write in a legible handwriting. Now, if I write in capital, that doesn't mean it will be legible. I can write my capital handwriting, everything in capital, but still it will be illegible. So guidelines are to be taken as guidelines. It should not be law. And if you don't follow the guidelines, it's up to you. And it's not to be taken as a law where you can be punished for not following the guidelines. So I think it was a wonderful session, very, very useful session, very informative session. Lots of ideas for thinking ahead. What should be guidelines? How should we follow? How should we improve our practices of writing prescriptions? And I think all of us will use this information and try to implement it as much as possible in our day-to-day life. Finally, our goal is same, that help the patient as much as we can.
Absolutely, sir.
Yes. And thank you, Paraksha sir, for such a lucid and such an informative session. It was really appreciated by everyone. I thank Shah sir, Nilesh Shah sir, to have provided his important inputs. And I would like to thank the IPS West Zone for organizing such an important and informative session. So I think we should conclude and thank you, everyone.
Yeah. Thank you and good night.
Thank you so much, both the chairpersons, for guiding the session and for answering a lot of questions and helping us to understand this better. Thank you.